Good morning, my respected teachers and my seniors. Today's topic is beta blocker and calcium channel blocker poisoning. I am Dr. Pallavi. As per the 2004 Toxic Exposure Surveillance System or TESS report, the 3% of the total exposures were due to cardiovascular medications. The cardiovascular drugs were the fifth leading cause of death in the TESS database, and CCBs and beta blockers accounted for 37% of these exposures and majority of cases resulting in death. Beta blockers and calcium channel blockers are widely used for a myriad of conditions such as hypertension, ischemic heart disease, arrhythmias and several other disorders. Although overdose with these drugs form a minority of all poisonings, but they may lead to severe systemic toxicity and also a high mortality. Management requires a multimodal approach guided by careful hemodynamic assessment to ascertain the pathophysiology, thereby guiding the choice of the most appropriate therapy. I will quickly go through the classification of beta receptors, mostly three types. I will discuss the beta receptors physiology and actions in later slides. Beta 1 mainly present in heart and kidneys, beta 2 mainly present in lungs and blood vessels, also in GI tract, bladder, uterus and liver, and beta 3 mainly in adipose tissues. Different types of beta blockers. Beta adrenergic blocking drugs are mostly classified into two main types. One is non-selective, having both beta 1 and beta 2 action, and another is cardioselective beta 1 action. Non-selective beta blockers might be without intrinsic sympathomimetic activity, that is a partial agonist effect on the receptor site, and with intrinsic sympathomimetic activity, and some having alpha blocking property in additional. Without intrinsic sympathomimetic activities, non-selective beta blockers are propranolol, sotalol, timolol. With intrinsic sympathomimetic activity is pindolol, and with some alpha blocking property is labetalol and carvedilol. And the cardioselective beta 1 blockers are metoprolol, atenolol, acebutolol, esmolol, betaxolol, etc. Generation wise classification, it can be classified into three generations. First generation, that is older and non-selective, propranolol, timolol. Second generation is beta 1 or more cardioselective property, this like metoprolol, atenolol. And third generation is additional alpha blocking or vasodilator property, that is labetalol, carvedilol, etc. Beta blocker pharmacology. Beta 1, they mainly regulate the myocardial tissue and affect the rate of contraction via impulse conduction. Beta 2, they regulate the smooth muscle tone mainly in the bronchial smooth muscles and GI tract, and influence the vascular and bronchial relaxation. Beta 3 mainly present in adipose tissues, they primarily affect lipolysis and may have some effect on cardiac inotropy. Some beta blockers may antagonize cardiac sodium channels that will increase toxicity in overdose. I will discuss this later. Beta blockers with membrane stabilizing activity like propranolol and acebutolol, they inhibit the myocardial fast sodium channels, which leads to widened QRS, and they may potentiate other dysrhythmias. There are different cardiological manifestations of different beta blockers and calcium channel blockers. One important is this widened QRS interval in case of beta blocker toxicity. This is due to the membrane stabilizing activity and sodium channel blockade property. But the intrinsic sympathomimetic activity, that is a partial agonist effect on the receptor side, some beta blockers having this, they show this protective function, and that might lead to less bradycardia and hypotension. Highly lipid soluble agents such as propranolol, they cross the blood-brain barrier and can result in unwanted CNS effect, which is not much common in case of calcium channel blockers. Next, we classify the calcium channel blockers, mainly classified into two major groups: dihydropyridine type of CCBs and non-dihydropyridine type of CCBs. Dihydropyridine type of CCBs, examples are amlodipine, nicardipine, nifedipine, nimodipine, cilnidipine, etc. Non-dihydropyridine classified again into two subgroups, phenylalkylamine, that is verapamil, and benzothiazepine, that is diltiazem. In case of CCB pharmacology, the voltage gated calcium channels are found in three sites, like myocardial cells, smooth muscle cells, and beta islet cells of the pancreas. Calcium channel blockers prevent the opening of these voltage gated calcium channels, and they reduce the calcium entry into the cell during phase 2 of action potential. It exhibits different selectivity for cardiac versus vascular smooth muscle cell channels. Myocardial tissue, in myocardial tissue all the negative effects like inotropy, chronotropy and dromotropy, all negative effects are seen in case of calcium channel blockers. Vascular smooth muscles, calcium channel blockers prevent the arterial contraction. There might be substantial vasodilatation. Thus there is reduced afterload and systemic blood pressure. Mainly dihydropyridine type of calcium channel blockers, they cause more substantial peripheral vasodilatation. Within the pancreas, the calcium channel antagonism, it results in decreased insulin secretion. Next we come to the clinical assessment proper. As per the history is concerned, we would like to first know about the agent. The specific agents like some membrane stabilizing agents, they may predict certain dysrhythmias like ventricular arrhythmias, widened QRS like propranolol and sotalol. Then we will ask about if it is an immediate release preparation or an sustained release preparation. Identification of overdose with any sustained release preparation, that may help to decide the role of GI decontamination. And immediate release agents, they might start showing symptoms or clinical deterioration within first 6 to 8 hours, and sustained release preparations, they start showing clinical deterioration within first 24 hours. We will also try to exclude any possibility of co-ingestion with any other drugs, if any. We will also know about the timing of ingestion and if there is any pre-existing cardiac disorder. Next is physical examination. As per the different types of the drug overdose is concerned, hypotension and bradycardia mainly is seen in cases of calcium channel blockers mostly due to the substantial peripheral vasodilatation, except in case of dihydropyridine type of CCBs like nifedipine, that may lead to reflex tachycardia. In severe overdose, though, this selectivity and this reflex tachycardia might lead to fulminant cardiogenic shock also in case of nifedipine overdose. Mental status, as I have already described, CCBs or calcium channel blockers are somewhat they are neuroprotective. So the mental status or orientation is somewhere normal in case of CCB overdose. But in severe shock, there might be seizures, delirium and comas, especially with the lipid soluble drugs like propranolol that crosses the blood-brain barrier very easily. As per the glycemic control, beta blocker overdose, they lead to hypoglycemia, and calcium channel blocker overdose, they lead to hyperglycemia due to inhibition of calcium mediated insulin release. This is the basis of insulin therapy. We will discuss that later. Next is laboratory investigation. Most important is we will do an ECG. There might be changes like bradycardia, PR prolongation and tachycardia. Mainly tachycardia in case of dihydropyridine type of CCBs. Might be widened QRS in case of membrane stabilizing agent, prolonged QT intervals in case of sotalol, and severe dysrhythmias. Also in case of pre-existing cardiac disorders, we have to also look for the pre-existing cardiac anomalies if there is any. Next is capillary blood glucose as hypo in beta blockers and hyperglycemia in calcium channel blockers. Relevant biochemistry investigations we will do, that is blood urea, creatinine, electrolytes and calcium. Chest X-ray, we will look for any features of pump failure or pulmonary edema. Serum lactate is a prognostic marker. If it is more than 3 millimole per liter, that may predict life-threatening overdose. Now there are some features which are specific to beta blocker overdose and some are specific to calcium channel blocker overdose. In cases of beta blocker overdose, excessive blockade of the beta receptors that may lead to bradycardia and hypotension. As beta selectivity is lost in case of overdose, even beta 1 selective agents that may also block the beta 2 and beta 3 receptors, and that also lead to bronchospasm and reduction in ionotropy. Lipophilicity is a good predictor of CNS depression. The more lipophilic agent is, the more chance of developing delirium and seizure. But beta blockers such as atenolol, they have poor lipid solubility, so they generally will not produce sedation. Cardiac potassium channel blockade due to sotalol and acebutolol, they may prolong QT interval and they may lead to torsidis de pointis. And cardiac sodium channel blockade due to acebutolol, carvedilol, betaxolol, they may lead to wide QRS and also monomorphic VT. Next, the features specific to the calcium channel blocker overdose. Most important is hyperglycemia. Calcium channel blockers, they cause a significant decrease in insulin release by blocking the calcium entry into the pancreatic islet cells. This lack of circulating insulin, it decreases the cardiac carbohydrate metabolism. It prevents the glucose uptake and use by cardiac muscles. So patient may present with hyperglycemia. Non-dihydropyridine CCBs, they may lead to myocardial suppression, early development of hypotension and bradycardia. Whereas dihydropyridine CCBs, they lead to vasodilatation initially, hypotension with reflex tachycardia at low dose, but that may lead to bradycardia and cardiogenic shock at higher doses. Next is treatment. Determining an exact dose for a given individual is difficult because the different non-modifiable factors are also there, like age, genetics, health status, co-ingestion of any other substance, elapsed time since ingestion when the patient is presenting late to the hospital, type of formulation, whether it was an immediate release or sustained release, patient has crushed the tablets or preparations or he or she has chewed the preparations. It also may disrupt the tablets release mechanisms. So these are the factors we should always try to keep in mind. Now in the management proper, first is activated charcoal. The dose is 1 gram per kg. When we will try to administer activated charcoal, when the patient presents within 60 minutes of ingestion, preferably within 60 minutes, but that can be extended up to 2 hours. Patient is cooperative with intact airway or the patient has been already intubated. No repeat doses or no co-ingestion is there. Then we can use activated charcoal at a dose of 1 gram per kg. We can consider gastric lavage and whether the risk benefit ratio is already in favor of us. We should always look for that also. Another thing we can consider, that is whole bowel irrigation. There is a solution available, name is Go Lightly, that is PEG in balanced electrolyte solution for the sustained release preparation, but it should also be done early before the patient goes into ileus or shock state. We will start at 1.5 to 2 liter per hour and reduce dose by 50% if there is any emesis. This is a preparation like colonoscopy. We will try to prepare the patient as we prepare the patient for colonoscopy procedures. Next is airway control and vascular access. We should always try to intubate early while achieving the hemodynamic stability. না স্যার এরকম কিছু দেওয়া নেই, মানে যতক্ষণ না পর্যন্ত কোলোনোস্কোপির প্রিপারেশনের মতো যে যদি এমএসসি শুরু হয়ে যায় পেশেন্টের তাহলে আমি ডোজ রিডিউস করে দেবো, আর যদি মানে যে অ্যাক্টিভেটেড চারকোল বা মানে চারকোল প্রিপারেশন যদি স্টুলে পাস করে তাহলে আমি বন্ধ করে দেবো, এরকম লেখা আছে। না এটা হোল বাওয়েলটা শুধু সাস্টেন রিলিজ প্রিপারেশনসের জন্য, সেটা আমি ইউজ করবো। বাট মানে ওটা ওখানে লেখা ছিল যে যদি চারকোল পার্টিকেলস স্টুলে পাস করা শুরু করে তাহলে আমি বুঝতে পারবো যে আমার অ্যাডিকুয়েট হোল বাওয়েল ইরিগেশন হয়েছে, দেন আই উইল স্টপ। বাকিটা আমি তাহলে দেখতে হবে। চেঞ্জ করবো। Airway control and vascular access. We should always go for intubation early while achieving the hemodynamic stability, because if we try to intubate the patient at a later stage or already patient is already hemodynamically unstable, post intubation hypotension or post intubation hemodynamic instability is more. So we should always keep in mind that intubation should be done at an early basis. Central venous access as well as arterial access as required. Echo can be done to assess the volume status also. Volume resuscitation, we should not go for volume overload. IV fluid, balanced solutions 10 to 20 ml per kg as a bolus dose should be used as a first line therapy. Next is atropine sulfate. Maximum recommended dose is 3 doses of 1 gram. Usually the first line agent for symptomatic bradycardia. Inotropes and vasopressors, first line agent is epinephrine. Norepinephrine can be used in patients with substantial vasodilatation. Next is the dictum is at least we should stock enough glucagon to treat one patient for 24 hours, 50 milligram glucagon in the limited resource settings. Antagonist therapies I am discussing in the next slides. Antidotes for beta blockers. There are different antidotes for beta blockers, mostly in use হচ্ছে glucagon and milrinone. Beta agonists, glucagons and phosphodiesterase inhibitors, but glucagon is generally recognized as first line therapy. Glucagon is a hormone secreted by the alpha 2 cells of the pancreatic islets of Langerhans. It activates the adenylate cyclase in cardiac tissue by directly stimulating a G protein coupled beta receptor complex. High dose glucagon is recommended. There is no maximum dose, but till what dose we should go for the glucagon antidote therapy, but high dose glucagon is recommended and loading dose is 5 milligram IV over 5 minutes. Then we should go for continuous infusion as the half life is very short, that 15 to 20 minutes glucagon's half life. Then 1 to 10 milligram per hour infusion at a continuous basis. Glucagon carries risk of aspiration, so if the patient's airway is not protected, then we should not go for glucagon. The alternative better therapy is milrinone. Sir? স্যার এটা হচ্ছে ফার্স্ট লাইন থেরাপি আর বিটা ব্লকের জন্য, তো ও মানে ডিরেক্টলি কার্ডিও টক্সিসিটি যেটা সেটাকে রিভার্ট করবে, যে এই বিটা রিসেপ্টরে যে জি প্রোটিন আছে সেটার উপরে অ্যাক্ট করবে আর কার্ডিও টক্সিসিটিটাকে রিভার্ট করবে, তাই তো লেখা আছে। হাইপোগ্লাইসেমিয়াটাকেও কারেক্ট করবে পেশেন্ট। Iron positive
global can increase the heart rate as well. Positive iron this pathway G protein mediated pathway का separate या कि pathway हो तो दाले भी तो already blocked है।
So change करो। Next is antidotes for calcium channel blockers. Calcium channel blockers are antidotes mainly calcium, glucagon, adrenergic drugs like norepinephrine, epinephrine and milrinone or amrinone. Unfortunately, these agents do not consistently improve hemodynamic parameters or ensure survival in severely intoxicated patients. Vasopressin can be suggested, but it has worsened the cardiac index. Different studies have shown that vasopressin has failed to improve the MAP in verapamil induced shocks. More promising antidote is high dose insulin therapy. Hyperinsulinemic euglycemic therapy, HIET, that is the most in use antidote for calcium channel blockers. Calcium is theoretically useful. It increases ionotropy. It improves BP by blood pressure by increasing the stroke volumes, but it has little effect on conduction blocks. Calcium gluconate was previously thought to be safest. Calcium chloride has 3 times more calcium than calcium gluconate. But there is a study, Lam et al. At 2001, their case report showed a calcium chloride improved blood pressure after calcium gluconate proved to be ineffective. The doses are different also. In cases of calcium chloride, 10% calcium chloride bolus is 10 to 20 ml in adults over 5 to 10 minutes, whereas the calcium gluconate dose is 3 times 30 to 60 ml in cases of adults. Not to exceed the calcium level of 14 milligram per dl or twice normal level of the ionized calcium. Always we should use the central line for calcium chloride infusion secondary to tissue necrosis. But if there is no central line and we have to go for calcium therapy, we should always opt for calcium gluconate. We should watch for arrhythmias with rapid infusion, and if there is any co-ingestion of digoxin and any other chances of digoxin toxicity, we should always withhold. The different adverse effects of calcium therapy is nausea, vomiting, constipation and confusion. Next is hyperinsulinemic euglycemia therapy, HIET. It is very useful in myocardial dysfunction, more convincingly in calcium channel blockers. It takes 15 to 60 minutes to work. There are 4 total parameters: insulin, dextrose and different electrolytes. We will start with insulin at 1 unit per kg IV bolus. Then we will increase, we will go for infusion 1 unit per kg per hour infusion. That may be up titrate every 10 to 15 minutes. Maximum dose is 10 units per kg per hour. Dextrose is we should go for 1 to 2 ampules of D50 stat, then 1 ml per kg per hour. The target blood glucose, we have to monitor the blood glucose first in the first few hours every 30 minutes, and then after the blood glucose is 125 to 250 milligram per dl, that is the target, then we will go for blood glucose monitoring every hourly. Potassium, we should keep the potassium level more than 3 millimole per liter, and also we should replenish magnesium and phosphate. The goal of therapy, when we should stop, then the systolic blood pressure more than 100 milligram of mercury and heart rate is more than 50 beats per minute with adequate perfusion, organ perfusion, that patient might have improved urine output and also improved mentation. Adverse effects of insulin infusion, there might be episodes of hypoglycemia and hypokalemia. So we should always monitor the blood glucose every 20 to 30 minutes for the first hour, then hourly along with the potassium monitoring. Infusion of dextrose should be started with the insulin bolus dose to maintain euglycemia. And insulin infusion may be tapered off once signs of cardiotoxicity has begin to resolve, and the goal of the therapy is being achieved. স্যার হ্যাঁ, মানে মায়োকার্ডিয়াল ডিসফাংশনের পেশেন্টগুলোর ক্ষেত্রেই শুধু এই জিনিসটা কাজ করবে, মানে যাদের অলরেডি প্রিজার্ভড কন্ট্রাক্টিলিটি আছে তাদের ক্ষেত্রে এটা লেস
Insulin increases the myocardial uptake of glucose and increases the myocardial contractility. And also when we give যে ল্যাকটিক ফ্যাক্টরগুলো অ্যাকুমুলেট হচ্ছে অ্যাসিডোজ হচ্ছে ইন্ট্রামাইক্রোয়াল সেটাকে স্টার্ট ক্লিয়ারিং এইচআইডি 9
চেঞ্জ করবো স্যার?
হ্যাঁ
I think dose is much higher, more than 10 units per kg, almost 30 to 40 units per kg.
30 it starts with 40 units per kg
40 units per kg.
ठीक है
40 units per kg.
This condition it's on बोलास्ता है पूरा 1 unit per kg.
मतलब 1 unit per kg নাকি
आगे बोला सा 40 to 50
হ্যাঁ তাহলে তো তাই হচ্ছে। নেক্সট
ডাইলুশন করতে হবে
কোনো ইউজ করিনি।
কিন্তু
ডেক্সট্রোজ একসাথেই শুরু করতে হবে। হ্যাঁ D50-তে এবং একসাথে শুরু করতে হবে, মানে ইনসুলিন আর ডেক্সট্রোজ একসাথে স্টার্ট, যাতে ইউগ্লাইসেমিক আমরা করতে পারি, মানে একটু হায়ার রেঞ্জে আমাদের টার্গেট ব্লাড গ্লুকোজটা রাখা হচ্ছে 125 to 250, মানে সেম টাইম। না না হ্যাঁ সেম টাইমে সে চেঞ্জ করুন। Next is different tier 2 therapies. First is methylene blue. In refractory vasodilatory shock, the dose is bolus 2 mg per kg over 15 minutes, then infusion at 1 mg per kg per hour. But there are some adverse effects like hemolytic anemia in patients with G6PD deficiency, methemoglobinemia, aberrant pulse oximetry signals, and also there might be serotonin syndrome that may occur or that may precipitate due to methylene blue exposure. Next is ECMO. VA ECMO is most effective, but there are less studies regarding this. In cases of cardiogenic shock, VA ECMO has been shown to be effective. Hemodialysis only for hydrophilic beta blockers. They won't work for the lipophilic drugs. Transvenous pacing in refractory bradycardia with preserved myocardial contractility. With any pre-existing myocardial dysfunction, the pacing won't work. Or next is lipid emulsion therapy. Lipid emulsion therapy basic mechanism is it forms a lipid sink around the lipophilic drug molecules, making them ineffective. The fatty acids from the emulsion, they provide the myocardium with an energy source. Verapamil toxicity, there might be some benefit in case of. New dose guideline is there. We will start with IV bolus 1.5 ml per kg of 20% lipid emulsion solution over 2 to 3 minutes. There is single jodi bolte hai tale 3 minutes. Then we will repeat 0.75 ml per kg over 3 minutes, and then we will start infusion at 0.025 ml per kg per minute until hemodynamic recovery. Thus maximum limit per day is 10 ml per kg. Next is sodium bicarbonate and IV magnesium therapy. That may be helpful in cases of sodium channel blockade and potassium channel blockade due to different beta blockers and calcium channel blockers. Increasing pH that may reverse the impaired contractility, and IV magnesium that helps to correct the potassium channel blockade. Messages: poisoning by beta blockers or calcium channel blockers, they usually produce hypotension and bradycardia, which might be refractory to standard resuscitation measures. For cases of beta blocker poisoning, where symptomatic bradycardia and hypotension are present, high dose glucagon is considered as first line antidote. But for cases of calcium channel blocker poisoning, where cardiotoxicity is evident, combination of calcium and epinephrine can be used initially, but high dose insulin dextrose potassium regimen is used for refractory cases. Thank you.
Very comprehensive. Just I'll says something, don't go so much into pharmacology. So clinical presentation of beta blocker beta receptor alpha receptor সবাই পড়ে আছে নতুন শুনতে বলে যায় very comfortable very well.
Can you use this HIT therapy after 4 to 5 days as possible?
No, it was only in the initial 40 rounds.
Send it to the room.
I know, 40 rounds of the
Very refractory cases. Refractory to the after 3 days.
have 40 doses.
Features of toxicity for the
you need to have viable marker.
Suppose a patient shifted to a hospital after 4 to 5 days. Then the role of this rate is insulin.
What is the role of pacing? Beta blocker toxicity.
হ্যাঁ লিখেছি হ্যাঁ বেসিক্যালি পেশেন্টে যদি প্রিজার্ভড মায়োকার্ডিয়াল কন্ট্রাক্টিলিটি থাকে তাহলেই শুধু পেসিং কাজ করবে, না হলে কাজ করবে না। Maximum 3 doses of 1 milligram each.
And after maximum, she watched the 5 days. Basically, we want to go little benefit. Refractive bradycardia থাকতে হবে কিন্তু প্রিজার্ভ মায়োকার্ডিয়াল কন্টেন্ট তবেই কাজ করবে না।
নালে করবে না। দুরকম হবে, একটা ট্রান্সভেনাসও হয়, আবার কিছু স্টাডিজ আছে যে ট্রান্সকিউটেনিয়াস পেসিংও আছে, কিন্তু খুব মানে আরও বেনিফিট নেই, সেরকম কিছু বলা নেই।
এবারে মায়োকার্ডিয়াল কন্টেন্ট কিন্তু প্রিজার্ভ থাকবে না, ইটস এক্সপেক্টেড যে সিসিপি পজিটিভ মায়োকার্ডিয়াল
জন্য বিশেষ
এটা ভালো উপায় হচ্ছে কি বাকি থেরাপি সাইমালটেনিয়াসলি দেওয়া হয়, প্রিভিয়াসলি সাইমালটেনিয়াসলি করতে হবে। ব্লাডে থাকলে তো মানে লিটল বেনিফিট থাকলেও তোমাকে তো দিতে হবে না স্পেসিফিক, and in the meantime you keep doing whatever is required.
আমাদের ক্যালসিয়াম গ্লুকোনেট রয়েছে, দুটো বিটা ব্লকার প্লাস ক্যালসিয়াম চ্যানেল থাকে, দুটো মিলে দিতে হবে
সিসিবিতে।
मोर ऑन द सेम है ग्लूकागॉन मेनली आपका बीटा ब्लॉकर के लिए स्पेसिफिक है, कैल्शियम उतना एविडेंस बेस नहीं है बट अभी दे सकते हैं, दोनों भी दे सकते हैं।
Muscular, most of the cases we see they are whatever they have and you have a co-poison. Insulins are seen, apple they use, and it increases blood pressure like dramatically. But patient doesn't live. There's a mortality benefit with more insulin. The parameters will improve. Some of the recommendation. We can use the same. সিসিবি যেগুলো ধরো পেরিফেরালি অ্যাক্টিভ মানে আমরা যেগুলো বলছি বা ডায়াবেটিস সেগুলোতে হাইপারটেনশন বলে কাজ করবে
স্যার জি
এরকমই বেসিক্যালি সেন্ট্রালি অ্যাক্টিভ মানে বেসিক্যালি কন্ডাকশন
ভ্যাসোপ্রেসিনের সেরকম রোল নেই, ভেরাপামিলের নিয়েই স্টাডিটা হয়েছিল একটা, সেটা আবার মানে হিউম্যান মডেলেও নয়, মানে একটা হয়েছিল কিন্তু সেটাতে কার্ডিয়াক ইন্ডেক্স আরও খারাপ হয়ে গেছে এরকম লেখা আছে। এই যে এইটা
যদি হয় তাহলে ভ্যাসোপ্রেসিন কম হওয়া উচিত। Metabolic is basically more of a central acting it's on conduction tissue then Amlodipine যদি high toxicity হয়, it will cause vasodilation, not bradycardia. I mean, alcohol will cause bradycardia, more brady than vasodilation. Vasopressin কোনো মানে লিটারেচারে পেয়েছো?
এই
কিন্তু অ্যাডনোয়ার্ডি লেখা থাকে, আমি পড়িনি।
হ্যাঁ, আমি জাস্ট এইটাই পেয়েছি, আর আলাদা করে লিটারেচার আমাকে তাহলে দেখতে হবে, দেখা হয়নি।
এখানে ফার্স্ট চয়েস কিন্তু অ্যাড্রেনালিন।
হ্যাঁ, অ্যাড্রেনালিন আর পেরিফেরাল। ফার্স্ট হচ্ছে অ্যাড্রেনালিন, তারপরে মানে নরাড হচ্ছে পেরিফেরাল ভেসোডাইলেটেশনের জন্য নরাড ফার্স্ট, মানে
একটা জায়গায় যেখানে you have to take care of the bradycardia, সেক্ষেত্রে definitely helps. नाम नहीं है, थोड़ा सोचने का स्टडी है, नाम नहीं है, चलो फैंसी नाम नहीं है। Basically symptomatic production, beta blocker হলে look up on a CCD or insulin, exactly what you try. That's it, CCD is the insulin. আর এটা হচ্ছে হলো অ্যাক্টিভেট চার্ট হলো ভালো হলো।
আর্লিতে
মানে এদিকে মডিউল অ্যাক্টিভেট চার্টগুলো ডেফিনেটলি দেখা যাবে।
এখন স্যার 1 ঘন্টার মধ্যে তো সবাই প্রেজেন্টও করে না, যে আমরা সঙ্গে সঙ্গে দিতে পারবো, ওটা সবসময় হয় না, যারা করে তাদেরকে দিতে পারবো।
Very well done. This can be potential study material. Keep it, distribute among our colleagues. I will also ask. और वजन बाकी है,
2-3 बाकी है।
लास्ट में ह्यूमर आएगा, ह्यूमर टॉक्सिक या ह्यूमर क्या आएगा लास्ट में, सब हो गया। चलो कैरेक्टर डिस्कशन देखते हैं, पहले हो गया ना।